Right, we've now started recording, so good morning everybody and welcome to the Northumberland Primary Care Commissioning Committee meeting. We'll start off with item 1 on the agenda. Welcome everybody. Apologies for absence. I'll tell you who I've got. I've got Richard Glennie, but welcome Jane, I know you're here instead, thank you. Chris Black has also given his apologies, but Adam Foster is here as well, so welcome Adam. And unless there's any changes, Barbara, I think that's all the apologies, is that right?
That's correct.
Thank you. And we've got no declarations of conflicts of interest which have been raised in advance, but as usual, if anything comes up as we're going through the discussion, please just call out and we'll deal with it appropriately, thank you. And we are quorate. So if we then move on to item 2, the minutes of the previous meeting, I'll not go through them page by page, but first of all, is there anything anybody wants to raise for accuracy? No, everybody okay there, thank you. Is there anything anybody wants to raise as a matter arising which isn't dealt with otherwise on the agenda or in the public action log? No, again, everybody happy. Thank you very much. In that case, we'll accept those minutes as a correct record of the last meeting. And that then takes us on to the public action log. And we've got a couple of things which are amber. First of all, the development of the standard operating procedures, which I gather is in progress and should be ready by the end of March. Everybody okay with that? Brilliant. And underneath that, progress on the recovery of practices and providing an update. Again, that is underway and will be provided at the April meeting. Again, is everybody all right with that? Good, thank you very much indeed. That then takes us on to section 3, which is the operational section. And straight in, as usual, John, to the finance update. Thank you.
Thank you. So you have here the finance update for month 9. We continue to operate under the umbrella of interim financial arrangements, and those arrangements haven't changed, but there is a recap of those in the report. What you will see in the position at month 9 is a pressure relating to the additional roles. This is around 400,000, but we do expect to recover further income to fund those roles, and actually that's to about £1 million, which leaves us a forecast position in this report of an underspend of 600,000. What we will do at month 9, or what we have done at month 9, is we will take some of the funding back into the CCG, the main CCG position, to get us back to that break-even forecast position, and we will manage it from there. What I want to make clear is this isn't taking funding, primary care funding, away from primary care. What it's actually doing is reducing the amount of funding that we are putting into primary care to cover the underlying gap that we have in financing primary care. So the money we receive for primary care is about 3.5 million short of what we actually need to spend, or what we have to spend. So it's just a reduction in that level of support, if you like, from this overall CCG position. I appreciate this is a little bit complicated, and it's a product of the way that we're working at the moment with the interim financial arrangements. So hopefully, as we move forward, we can get back to a more kind of usual way of reporting, and once we move out of interim measures, which should be from the 1st of April. So I will leave it there, Chair, and just invite any questions.
Thanks very much, John, and thank you for confirming the position about that funding, because I think we've discussed it a lot, and I think our GPs are aware that the CCG has been subsidising, if we can use that word, subsidising the growing gap. Yes, I know it's perhaps the wrong word, but it has been funding from general CCG funding, the growing gap in primary care. So as you say, there's no loss to primary care there. In fact, the CCG has continued to support primary care quite rightly. Jane, I think you want to come in, and then Karen, thanks.
Thanks very much, John. 2 questions, thanks. I mean, one is just acknowledging the ongoing ARRS funding and just how we, I don't know how you're planning to keep a sort of track of that, because it is increasingly over the rest of this term of the current finance GMS, or the current primary care contract, going to become an increasing proportion of the overall funding, and it's really about sort of the equity on that. I know that's not necessarily within your gift, but it's really how we're going to monitor that and not creating unintentional inequities across the county. I know you can't answer that, but it's just sort of a pointer, and you know where I'm coming from in that sort of the differential use of the ARRS and the various shall I say torturous rules around it. The second thing is, are you in a position to update us yet on, as of the next primary care committee, we will technically only be a month or so away from the ICS arrangements, and how we're going to amalgamate primary care funding management across our place, or not least our ICS.
Thanks, Jane.
Sorry about that.
No, there's quite a bit in there, Jane, isn't there, as you know. So I think on your first point, yeah, I think that's a good point in terms of the way the additional role stuff works. That will be an ongoing challenge, I think, as you say. In terms of your second point around the development of the ICB and how that will work, obviously we have a revised timetable for the start of the ICB, which is the 1st of July. We understand that timetable could slip further as well, and that's been kind of acknowledged in the sense that this has been defined as a target date, is the way that it's been described. So we need to be conscious of that. Certainly in the initial proposals around the governance of the new ICB, there's been a suggestion that if you like, core delegated primary care will be managed on the whole ICB footprint. I see some practical difficulties with doing that, and not just practical difficulties, but also is that the best way of doing it? I think there remains a question over that. The ICB clearly is not yet in place. We do know that the board members are in the process of being appointed, and there are quite a few of those interviews this week and over the next week or two. So, and we have now a chief exec in place who is a designate chief exec who arrived at the beginning of February. So I think what we're seeing now is the people that are able to really make these decisions are starting to come into post. So we hope for a bit more clarity around that and how practically things are going to work. But I think we are still some way away from knowing exactly practically how this is going to work in future. So I think you're absolutely right to raise it as a point. I think there is concern over the timetable and the amount of work that we've got to do. And I wish I could give you more clarity on that right now, but I just can't.
I just think I just wanted it to be noted for this board about the potential risks to Northumberland primary care as a whole when viewed with the lens of the ICB primary care funding and the various equally difficult arguments they are having, but that other areas are in completely different positions compared to ours, as far as I understand. Anyway, it was just sort of make sure we're sticking up for Northumberland in the bigger picture.
Thanks, Jane. It is an area of great concern, and we have added a standing item onto this committee agenda about the developments for managing primary care within the ICB and the ICS. And unfortunately, at the moment, there is no guidance. There are no real indications, and it's a serious concern, particularly for this committee, for the CCG, and also for the patients, because remember, the figure often quoted, isn't it, is around 90% of patient contact with medicine is through primary care. So the vast majority of all services accessed by patients in this country are through primary care. So it's a huge concern for this committee, and you're absolutely right, we've got an eye on it. Karen, you wanted to come in, thanks.
It was just a question about the GPIT. I don't know why I've never questioned this before, but how do we monitor the spend that NECs make on our behalf for this? Do we do it through our monthly NECs meetings?
No, we tend to do it through the CFO group.
Okay, oh, because it's across the whole area. Yeah.
Yeah.
Okay, thank you.
So we have a lead in the CFO group who works with NECs on that at a high level. But you know, we do local things as well directly from the CCG. But in terms of that overall position, it's through that group.
Okay, thanks.
Thanks, Karen. And welcome, Siobhan. I know you were at another meeting. You've obviously managed to join us quite quickly. So good to see you.
Thank you.
That now takes us on to item 3.2, which is the contract baseline report. And I think, Adam, you're addressing this one for us. Is that right?
Thank you, Janet. Yeah, so this is just a baseline report for Northumberland, just for information for the committee to consider. The report gives details of any contractual changes or issues that have occurred or are currently in progress. The report also gives an overview of QAF attainment, DES sign-up and activities. In section 5, under mergers, it notes the recent merger of Widrington with Felton, and the new practice names given as Northumberland Health. Section 5 also gives the practice branch sites. It gives a list of the branch sites. And in this, it's worth noting for Alnwick Medical Group, the Long Horton branch, the engagement for that has now begun. So they've embarked on that. Now, the appendices of the report, this gives the information on the DES and the QAF attainment. I would like to draw attention to the minor surgery DES first. This report's quarters 1 and 2. Now, just for the committee's information, really, quarter 3 and quarter 4. Well, quarter 3 is going to be partially income protected, and quarter 4 is going to be fully income protected. In quarter 3, it's going to be December onwards, December only, sorry. And that's only for practices which have signed up with the COVID vaccination service, which I believe everyone in Northumberland signed up to. I don't think there's anybody who hasn't.
Yeah.
Now, with the learning disability DES, there is an error, and apologies, I failed to spot this before I submitted the paper. It's in the total money earned column. This looks like it's been calculated using the total number of patients on the register rather than the number of health checks performed. So it looks like everyone is doing extremely well in that table. Now, I have spoken to Hannah, who produces these reports, and she's going to update it this morning. So I can provide the updated paper later on this afternoon, just for the committee's records. Again, I can only apologise for this. It's just a lack of oversight on my behalf. Apart from that, I mean, there's nothing really else I wanted to note, unless there's any other questions the committee had. I'm happy to answer them.
Thanks very much, Adam. Questions, comments, David, and then Karen. David, you're on mute.
Thank you. I think the section on learning disabilities comes in this particular report, but I haven't got access to the papers because it's come up as hieroglyphics. Anyway, I think there's something there about learning disabilities and the enhanced service for health checks for those with such disabilities on a register. There seems to be significant variation in the proportion of those GPs who carry out checks. I know general practice is under huge pressure, but the range seems to go from 0% to 68% of those on the register. And most are below 50%. And bearing in mind, I think there's a link between learning disabilities and physical health, etc., and therefore added pressure on the system. Should steps be taken to raise the proportion of people who are having health checks on this register, or is that unrealistic?
Thanks, David. Adam, is that something you can address?
Not really, no. I mean, it depends on the practice's demands, how they tackle these issues. You know, I couldn't really speak for individual practices on how they do address the learning disability registers and how they're going to engage with these patients to get them in for the health checks. So it's not really something I could comment on, unfortunately, you know.
I understand that, but I've got Robin and David and Annie all possibly able to come in on this. So that's the order I saw you in. So we'll start with Robin. Did you want to address that, Robin?
Yeah, well, just to reassure you that, I mean, this remains a focus on our monthly quality reports at CMB. We have very good GP leads, Kathy Peterson particularly, who has been doing a lot of work engaging with practices to make sure that the processes are streamlined. The reality, however, is that these learning disability health checks take around half an hour to 40 minutes to do correctly. So they are, and they can't really be delegated to anybody other than a GP. So we have a situation of, yes, there is acknowledgement, and I think there is. I'm confident that practices understand the importance. That the confounding factors have been blood bottle shortages at back end of last year, as well as you need to protect time to do these LD health checks. But at the same time, we've got pressure on access, and everybody's clamoring for a face-to-face appointment. There's a presentation to OSC next week by Graham, and I'm going to be sitting in on that one as well, talking about access, because politicians are getting a lot of complaints about how they're not able to get appointments. And then the other thing about the data is remembering that some practices have a large number of LD individuals, whereas other practices are very small, and as a result, the percentages can vary dependent on how many are on their register and how many checks have been done. So all I would say, look, there's no complacency from our part. We are trying to push practices or encourage practices as much as possible, but they are trying to manage competing demands here. Yeah, that's all.
Thanks very much, Robin. David, I see your hand's gone down. Has Robin picked up?
Very much so. I think Robin covered it very nicely, but as you're aware, I flag it both to CMB, and it's one of the areas that I flag to governing body, and it's also part of the quality assurance process that we have for practices, and it is one of the areas of focus as Robin's just outlined. Thank you.
Could I just add, Jenna, thanks for the response. And I did mention that, you know, I do understand, like everyone else, the huge pressures on general practice. You know, that goes without saying. But there's a huge agenda now on inequalities, and you know, these people with learning disabilities, you know, in many ways are disadvantaged anyway. So I think it's just on behalf of those disabled patients on the register, you know, that I thought it was important to raise it as an issue, because it potentially will have a significant effect on those individuals.
Yeah, thanks, David.
Thanks for the response.
And Annie, did you want to add anything, or was it a different matter?
No, it's just to add to it, but without repeating everything that David Robin already said, just want to give committee some assurance at the operation level that we have a transforming care group meet regularly with the clinicians across different parts of the system, and all the physical health indicators like health checks, vaccinations are standing agenda items. And we also work with the learning disability nurses, because they also have a very kind of close and good relationship at a practice level, and also with the service user, and sort of supporting them, taking through them all these sort of checks and screening, including, like, you know, cancers and other thing. And also from an inequity perspective, David, you know that we have a Northumberland Vaccine Equity Board. We also actually closely monitor, I know this is not sort of related to the enhanced services, but in terms of the flu and COVID uptake of from people with learning disabilities as well. So that's very much definitely on our agenda at both sort of kind of more strategic and operational level.
Thanks very much, Annie. Karen, I think you're moving on to something else.
Yes, it was just a question about the GP retention scheme. To Adam, yes, please, I would like an update in the private bit about that and value for money. But also, I'm just wondering what happens after the 5 years of being on the retention scheme?
Does anybody have a quick answer to that? If not, we'll get one to you, Karen. Robin?
Well, my wife was on the retention scheme for 5 years, and then she had the option then of becoming salaried. So I think and then she became she was in a practice. She was on a retaining scheme. It came to an end, and then she decided to remain in the practice on a salaried contract. But it supported her during the birthing years, so to speak.
Okay.
And Adam, do we track those sorts of things so that we know? I mean, obviously, if we've invested for 5 years in somebody, and then after the 5 years they just disappear, you know, we don't retain them. Do we track that to look at value for money?
I mean, it's something I could ask internally. I know they do ask the reasons why they're leaving now, and there's got a standardised form for that. But yeah, I mean, it's a good question. I mean, I'll speak to the lead, Kelly, who deals with it, and I can get an answer back for you.
Okay, thank you.
Thanks, Adam. I think that the tenor of these questions is that the committee has always been concerned that we have no real control over the GP retainer scheme, and sometimes we get applications which are really good, and there's other times we get applications which are perhaps supporting services in areas which don't need them quite so much. And it's just a general concern about value for money in quite a high spend. Jane, did you want to come in briefly on this one?
Yeah. Yes, just very briefly, just to point out to the committee that there are several types of different retention schemes. There's the one I think Robin's wife might have been on, which is the old retainer scheme. The current retention schemes, of which there are several iterations, were incredibly more expensive to our GP community than the old retention schemes, which used to be often funded through the academic circles and were incredibly good value because they kept people in. And I think you'll remember that I actually pointed out about 3 or 4 years ago to this committee that the retention schemes were potentially very inequitable because the go-ahead practices who'd got their ear to the ground applied for the posts and often got them. And we're seeing, you know, and as you know, there was no, as there is with a lot of these things, there was no compulsion on the incumbents to stay or do anything particular for Northumberland. And we're just seeing the, you know, and as we see from the information that's being presented to us, there is a difference in the way they've been taken up. And they have been a considerable expense to our GP community, but hopefully we'll have got some good people out of it. So I think with these schemes, they look good at the time, but we have to think about the long-term consequences and how it actually affects the equity. So that really, I think, is for background information, that there are an awful lot of good schemes that appear to be sort of handouts at the time, but we have to think about how they affect our overall workforce.
Thanks, Jane. In that case, I think we're happy to accept the contract baseline report and move on to 3.3, which is the out of hours assurance report. And you'll remember that we have a slightly updated version of that was circulated earlier this morning. It doesn't change the content and sense of the report. It just changes, I think, some numerical notation in the report. So I think this one is David. Is that right, David? You're doing this for us?
That's right, Janet. Thank you very much.
Thanks.
Good morning, everybody. Yes, apologies. As Janet explained, there was a mislabeling on the report, so I'll cover that a little bit more as we go on. For those who have not met previously, I'm David Kyle, Commissioner and Contracting Manager at Northumberland CCG. So I'll take us through the out of hours assurance report covering Q1 and 2. I'll largely speak through exceptions within the report, but we'll add context where I think it's necessary. But if there's any questions, please do let me know in any of the areas. So in terms of quantitative performance, you'll note that tables 1, 2 and 3 all show performance against a specified timescale. The reason for that is historically referrals to the GP out of hours service originated solely from the 111 service. However, in 21-22, VOCA agreed to receive direct contact from identified healthcare professionals and services to support the system. So table 1, sorry, yes, was there a comment there, Janet? Or
No.
Oh, sorry, to apologise. So table 1 shows the performance against referrals received from 111, and that's against the NHS Pathways Determined Disposition timeframe. Whilst tables 2 and 3 show performance against all referrals received from any healthcare professional or service. Where there's no disposition timeframe specified, the healthcare professional in combination with VOCA will determine a safe timeframe. So, as you can see from table 1, the GP out of hours service performance in respect of patients referred by 111 and seen either in a centre or in their own home is largely of a good standard. The target is more than 95% of patients to be seen within the specified time frame. However, the main area of challenge in Q1 and 2 and in previous years is where patients need to be seen within 2 hours and below time frame, with both quarters slightly below the target by circa 1.5%. I think it is worth noting to the committee that over 40% of all referrals from the 111 service in quarters 1 and 2 had a disposition timescale of 2 hours and below. So that can cause significant challenge for the out of hours service. As we know, 111 disposition timescale driven by the national NHS Pathways triage system based on the balance of risk, and feedback received from the out of hours service suggests that perhaps an intermediate disposition time frame of 2 to 4 hours would be desirable in assisting the out of hours service to manage their workload whilst maintaining patient safety, but that's obviously a national issue. So yeah, before moving on, I'd like to just add to what Janet explained before. I'd like to apologise, though there was an error in the report previously circulated. So in respect of the labelling of tables 2 and 3, so that's page 8 of the report I provided and page 46 within the papers. So table 2 of the previously circulated report actually showed performance against appointments at a centre, whilst table 3 shows performance against home visits. As you know, this has been corrected and we've recirculated that. So tables 2 and 3 of the updated report show the GP out of hours performance against referrals received through all channels, not just 111. And as you can see, VOCA are exceeding the target for centre appointments carried out within the specified time frame. In respect of patients seen within the specified time frame for home visits, as outlined in table 3 on the corrected version, performance is not at the desired level. So in Q1, attainment was 88.1% and Q2 was 83.6% against a target of more than 95%. So in explaining the challenge in this area, VOCA have advised that in respect of home visits, obviously the rural nature of Northumberland's geography can make attaining a home visit target a bit of a unique challenge. They've also explained that there's extreme pressures on the service, both in terms of patient numbers and staffing issues, that's staff absence, and also attracting additional staff. And in order to mitigate staffing issues, VOCA is actively recruiting and have increased the associated rates of pay. In order to reassure the committee, where a home visit is delayed, the GP out of hours service do safety net the situation by making a call to the patient to establish if there's any changing or worsening of their symptoms, which would need to be considered and then acted upon in terms of reprioritisation. As we move through the report again by exception, table 5 shows the percentage of patients that needed to be admitted to hospital, whether via an emergency assessment unit or where the patient's known to a specific ward. Whilst the target of this is less than 4% of patients being admitted was not achieved in Q1, it was in Q2. I think it's worth noting that a benchmark was only agreed in this area for the year 21-22 based on a stretching target when considering performance in the previous 2 years. So as we know, the last 2 years have been anything but normal, so performance in this area will be monitored and considered going forward. In terms of qualitative performance, attainment of a good standard, I believe, and we can be assured that VOCA provides a safe and quality out of hours service. Incidence as a proportion of overall contact is low and relatively consistent. It's worth noting, as outlined in the report, that VOCA capture and report on all incidents combined, so that's all internal incidents, and I've described that within the report, obviously. During Q1, a bit of a theme emerged with regards to the disposal of patient identifiable information. So there was 3 incidents of that type in total during Q1. Actions taken to improve were feedback to the individuals, obviously, wider communications to all staff, and then signage being erected within the centres and vehicles as a reminder. So it's pleasing and reassuring to know that there's been no further incidents of that type in Q2. And further pleasing that there's been no serious incidents in Q1 or Q2. Complaints, again, as a proportion of overall contacts, are very low, and upon investigation, none of the complaints were upheld in part or in whole, and 4 out of those 5 complaints related to the patient's perception of the care provided. Clinical audits in order to drive continuous improvement, quality and patient safety. Each clinician has at least audits completed. That's 3 audits completed on their triages by a senior clinician. Again, performance was good in that area, no red flags, no outliers. And again, with regards to clinical breach reviews, all cases with a breach time of 10 minutes or more, so that's where it's when 10 minutes or more with the appointment time, which then result in ED or ambulance response, or clinically reviewed to ensure that no harm was caused by the delay in care. And investigations determined there were no occasions of harm caused by those delays by the out-of-hours service in quarters 1 or 2. So I think in summary, I think it's reasonable to say that the out-of-hours service is performing well, though not without challenge or areas for improvement. And I believe we can be assured that Fogare provide a safe and effective service that identifies and acts upon learning opportunities in a timely manner. I'm happy to answer any questions that anybody might have at this point.
Thanks very much, David. Questions or comments from members? Karen, thanks. You're muted, Karen.
Sorry. One comment about the doctor being shot at. That's very worrying, isn't it? In the report there. I don't know whether whether there's a particular area in the county that we perhaps need to think about security for people going out, but it's just appalling that the public would do such a thing. But that's by the by. I just wanted to ask, you were saying about you check up on the incidents related to delays. Just coming back to the 2 hours and below on table 1, it's around about 40 patients that didn't get seen within the 2 hours, looking at the figures there. Do you actually directly look at those 40 patients as well, and then see whether there were any incidents related to them for the delay of the 2 hours, and knowing
well, they're actually, as I said, if it feels like there's going to be a delay, they are contacted themselves by the service to check for change or worsening. I don't think there's a full investigation carried out on every patient whereby they've not been seen in the particular time frame, to be honest, Karen. Only where that's then led to further care in ED or an ambulance response.
Yeah. So but you would identify, therefore, if there was an issue. It's to know, really, isn't it, how much it matters, because these are just proxy indicators in a sense, aren't they, these 2 hours and so on. It's the best guess as to what the time is, so it doesn't seem as though it's too problematic.
No, I don't think so, Karen. And like I said, I think, Vocare do take it incredibly seriously. And I think within the system, if they go over the timescale and then, they'll receive an alert as to what's happened with the patient afterwards, or so that's when they would look into it and investigate it further.
Yeah, thank you.
Thanks very much. Annie.
Yes, I just want to add to it. Karen, in those cases, if there's any patient harm as related to the delay, I kind of would have expected those reported as incidents. But obviously, so at the moment, they haven't reported as incident. I'm not saying that there's definitely no patient harm, but no patient harm probably known to the service as such. But that is what probably I'll try to do some triangulation.
Yeah, that's right. I mean, what I don't believe I've captured in the report, because we receive so much information that obviously I have to try and focus it a little bit. But there's a process whereby healthcare professional feedback forms are sent by either everybody who's involved in that pathway. So it could be from NEAS 111 service all the way through to kind of A&E. So that healthcare professional feedback goes each way. And again, upon investigation, if it's determined that any harm was caused, as Annie says, that would then be raised as an incident or a serious incident, whatever the case may be.
Okay, thanks very much. In that case, thank you for the report, David. I think, as you've said, although clearly there are some failures here and there in the report, overall, most of the targets are either being met or only reached by a very small percentage, I think the committee can be reassured that they've considered the contents, and I think it is, generally speaking, a reassuring position, and we know that where necessary things are being acted on. So thank you very much indeed. And that then takes us on to item 3.4, which is on access improvement. A bit of a hot topic, as Robin already touched on earlier. And I think over to Claire and Emma. We are a little bit pushed for time. So perhaps if we can try and manage to complete it within 5 minutes or so, that would be good. Thank you very much.
Not a problem. I'll just load a quick PowerPoint presentation that Claire and I will go through.
Thanks.
Thank you. So, morning everyone. For those of you who don't know me, I'm Claire Lynch and I work in the primary care team. Emma and I are going to do a bit of a double act this morning and talk you through the Improving Access project. I'm going to do the background to the project and the reasons why we've commissioned the service, and then Emma's going to take you through the more interesting elements which show some of the interim findings that have been produced so far. Thank you, Emma. Okay, move on to slide 2, please. Yeah. Thank you. So as we all know, it's already been mentioned earlier, over the last couple of years during delivery of primary care medical services have had to be delivered in a slightly different way due to the pandemic. We've seen the mandated reduction around face-to-face appointments. We've seen the accelerated implementation of digital tools around online consultation, video consultation. And some of these changes haven't necessarily taken into account the infrastructure within practices and their ability to adopt some of the online tools, but also it hasn't been an opportunity to reflect on patient expectations around accessing their primary medical services. Sorry. It's all right. So, yeah. And alongside all of this, what we've all already touched on earlier is that the media often portrays that there's still a perception out there that general practice remains closed to patients. Well, obviously working in primary care, we know that's not the case, but it does lead to a challenge around raising the awareness of GP access with our patients and making sure that patients know that there is an opportunity to have a face-to-face appointment with your GP at the moment. But what we also are encouraging is that we're signposting patients to the right care at the right time with the right professional, whilst also delivering primary care services during a pandemic. Next slide, please, Emma. So what the primary care team did back in summer last year, we submitted a funding application for some system development funding. We were awarded some money, and it was a real opportunity for the team to develop develop a bespoke research project looking at access and the impact. And I don't know what's gone on with the slides now. I can't see it. It's all right for me, but just might be for when you need to pick up your elements. So yes, it was a real opportunity for the primary care team to work with some of our stakeholders, practice managers, to design a bespoke research project that would focus on patient experience, patient expectation, but also how it felt like within practices around access and what it felt like on the front line in terms of delivering those services. So what the plan is, that the CCG have commissioned explained market research to develop a real local place-based engagement project that will take into account both patient experience, practice experience, but also working with our voluntary and community sector. That engagement started in mid-January and will run until the end of March. And Emma's going to take you through some of the interim findings that we've received so far, which actually so far it's really positive. So we're really pleased with the results so far. But obviously at the end of March, what the intention would be is to pull together a local action plan based on the research, because although we have the interim findings, we still don't know what the full engagement is going to tell us. But from that, we'll develop a local action plan, which will be shared with our patient, with practices. And Sorry, I just was distracted there by the slides again. And then obviously the data that we collate will also help us as primary care commissioning team to support our commissioning intentions for future service delivery. It is an interim presentation today. Our intention is after March to come back to committee, possibly invite and explain to come along and do a delivery on the presentation so you can hear firsthand some of the feedback from members of the public as well as our practice staff. But it is interim findings so far, but some of the results are really pleasing. But I'm going to hand over to Emma now, if that's okay. Emma, do you want me to go through the slides? Are you okay?
I'm okay going through. Can everybody still see the slides?
Yes,
Yeah.
but it's showing project scope at the moment.
Yeah.
Thank you very much, Janet. Okay, so on to the next slide, just to go through the engagement methodology. As Claire said, we've commissioned Explain Market Research, and they came up with a very comprehensive engagement plan for us. And so we've commissioned them to deliver 500 face-to-face on-street surveys. That is also being reproduced into an online survey, and we've made sure that there are paper copies available, and we have been distributing quite a few paper copies for those that don't have access to the internet. They're also carrying out 7 focus groups with members of the public, 24 in-depth interviews with a range of practices from each PCN area, and they're also they've produced an online survey which is going out to general practice. And then separately, we at the CCG, we've commissioned some outreach surveys and focus groups which will be delivered by the voluntary sector. Specifically, we've commissioned 3 VCSE organisations to lead some discussion groups as well, with 8 members of the public in seldom heard groups that we don't often hear from. And we've also commissioned 4 other VCSE organisations to help groups that we don't hear from again regularly to help complete the paper surveys or online surveys. So progress today, as Claire has already said, the engagement started in mid-January and we're halfway through now, so it's almost going to be finished on the 25th of February. Explain have managed to almost complete the 500 surveys that they've set out to do. They've recruited to all of the focus groups and have booked. Some of those focus group sessions are already booked, and I think some have taken place already. And we're really thrilled with the response that we've had to the online survey, and we've had over 2,000 responses. So the interim results that we've received in terms of satisfaction, as you can see there, satisfaction, unsurprising, has dropped since COVID. We've also asked in the survey about how people would like to, how they would like to book their appointment. And as you can see, 61% have said that their phone call is their preferred method. In terms of whether they've had a video or a telephone appointment within the last 12 months, 77% have said that they have had a telephone appointment. And in terms of how satisfied they were with that, you can see combined 65% of respondents, which is combined satisfied and very satisfied, are with that telephone. But we've also asked, we've also asked if respondents would be willing to have a telephone or a video appointment in the future, and 33 of them said, 33.5% said they would if it was for a routine appointment, but 15.3% said no. But overwhelmingly 50.2% said that it would depend on what the issue was. And for another scenario, we asked if they had an unexpected illness or an injury, and again 49.9% couldn't really answer that. They said it would depend on what was wrong with them. So we also asked for people's perception of healthcare professionals, and as you can see there, predominantly most people obviously aware of their GP and their nurse, but I think there is still some work to do just to try and increase the awareness of physiotherapists, pharmacists, and the other healthcare professionals that do work in practice. So the survey also just go on to ask the participants to think about different situations that and how they would respond, and how access would be preferred for them in different situations, such as if a family member might need an appointment or themselves. So in the scenarios such as like a one-off illness that they haven't had before, or a routine health appointment, for example, like a checkup that wasn't urgent. We've also asked them to think in scenarios if they have a long-term condition, and think about the scenario if they have a child that has a one-off illness. So in these scenarios, we've asked them to think about who they would like to see, how quickly they would like to be seen, and whether evening, weekend appointments would be preferred, or telephone or video appointments would be preferred. And a similar approach has been adopted by Explain and all of the focus groups that they've taken, that they're carrying out for us. So in terms of next steps, I think Claire did outline quite a few of those earlier. The fieldwork and the surveys are going to be closing in a couple of weeks' time, on the 25th of February. The focus groups and the practice interviews will also be finishing at the end of the month. So Explain will be carrying out their data analysis throughout from the end of February to throughout early March, and then they will be presenting us with a final report at the end of March, and we will be looking to ask Explain to present to PCCC if that would be required, and then the CCG will have to go away and will review those results, and a working group will develop a plan. Are there any questions?
Thanks very much, Emma. That's really interesting. Probably fair enough to say so far there haven't been any shocks, is that right? And it'd be really interesting to see when you get the final results.
Yeah, nothing particularly unsurprising. We're expecting some of those results that we've seen so far, definitely. So
questions, comments?
It's comforting, but it's comforting to get that, and it's really comforting to have something tangible in front of us to show that you know what people's perceptions are and what they prefer to do.
I think particularly as you touched on, there is very significant publicity, isn't there? Usually about the difficulties of primary care access. So yes, really useful to have the facts. I think I've got Pamela, Robin and Rachel and Annie. So Pamela first.
Yes, just quickly, I think as I think from the first, some of the slides that Emma went through, understanding that virtual remote consultations, I think I was surprised by some of the responses in that. I think it's really interesting to just gather that intel, which we haven't had before. And I think the other pertinent point is with some of the interviews, we're going through the demographics of the population to understand, you know, what background do they come from, which employment areas, and that helps us just map the results with the different demographics across the population and different areas, which helps us tailor and understand a little bit more about what the population expect, what they need, and how we can respond to that. And it'll also help us with extended access, weekends, bank holidays for families and children. So I think it's a really comprehensive piece of work, but I think we've spent a lot of time to try and gather as much information which we haven't maybe had access to in the past.
That sounds really good add-on as well, the demographics. Thanks, Pamela. Robin?
Yeah, I just wanted to say I'm very pleased with the progress of the work so far. I mean, when Pamela and myself identified some funding which we bid for and received, that we felt this was the right direction to go in terms of trying to reset. Number one is what the public's perspective was. But actually, it's also very important to recognise that we are asking practices what they think as well, because this is not just a one-sided conversation. It's very difficult to explain to the population what goes on inside practices, all our hidden work. You know, they walk into a waiting room that's quiet and they think the GPs are doing crochet or something like that. So it's very important that we do actually have a two-way conversation and it facilitates that two-way understanding of what's going on. whilst at the same time it's really important. The reason why practices are there is to provide care to patients. So that's why they're there. But they've also got to have the opportunity to articulate how they are responding to the pandemic and the future models of general practice. So just want to thank the team for all the work they've done to date, and I'm really looking forward to seeing what the results are going to be.
Thanks very much, Robin. Rachel?
Thank you. Yeah, I mean, pretty similar to what Robin said, actually. Well done. It's great to be doing some proactive engagement rather than on the back of, you know, a move or a change. I think that's really significant, and I think the early findings are good, and clearly the topic has been very well received by the public, by the returns, which is excellent as well. And, you know, there's still a lot of transformation to do with primary care, isn't there? And, you know, COVID transformed it massively to using video and telephones in a different way. So it's really good, and I think equally it is interesting to hear about the other health professionals and how they're not recognised as much, because that just shows you know, that branch of work that we probably need to focus on going forward. So really well done, really brilliant piece of work. Can't wait to see the final report. Thank you.
Thanks, Rachel. Annie?
Yeah, just echoing all the positive comment. Really looking forward to see the report. I'm just thinking, Claire and Emma, do you think at this stage, do you have a feel that we are reaching out to all sectors and all communities in Northumberland? Obviously, not just geographically, but because I'm still very conscious that primarily most of the people here are white, and some of the inequalities and disabilities perhaps is not as visible. So I'm just thinking about, before we finish this project, do you think there's still any more work that you already plan or you're going to do to make sure that we are kind of like bringing all the voices and experiences to inform this piece of work, really?
I don't know if you recall, I said that we've separately commissioned some VCSE organisations, and we've approached Being Women, and we're actually we're funding them £1,000 to carry out some focus groups with people from BME, BAME groups. So it's something that we've definitely recognised, and it's something that we've had to do and included in this project. We've also gone to Carers Northumberland, and we've also gone to Silks, who are going to be reaching out to children and young people. So we really have made sure that this is representative of the community of the county.
Thanks very much. Good point. Thanks, Annie. Yeah, it's very important. David?
Thank you. Just to echo what has been said, it's very reassuring that such an in-depth survey has been conducted to find out what's going on, particularly involving the difficult to reach groups. I think that's a step in the right direction. And the general tenet of the interim responses reflects the view expressed in the Health Watching annual report about access online and so on. And the general view from the Health Watch England research was that patients somehow need to feel comfortable about the online survey, online consultation, and so on. But one cautionary note: there are many people in society who don't have access to computers, IT, and so on. And again, they are disadvantaged in many ways. I think we just need to be mindful of the fact that some people would always find it difficult because of facilities in their own homes to make access online. So I think we must be mindful of that group of people who are quite a significant proportion within society.
Thanks, David. But thank you both very much. Sorry.
Can I quickly come in on that, please, Janet? Just to reassure David, as I outlined, we have distributed quite a lot of paper surveys, so we haven't received the findings of those yet. So it'll be interesting to see the difference from the responses from the paper surveys, because they are going out to those people that don't have access to the internet.
Good. Thanks, Emma. And Karen, you wanted to come in?
Yeah, just to say, when I met with Emma recently, just for an update on the engagement, she also mentioned for the first time we're actually paying some of the VCSE people that we're commissioning now. We're actually giving them money to do it, which I think is a positive move forward, whereas in the past we've kind of expected them just to do it for us. So I think that's a real positive. The other thing just to say is I think also there's still a big education need for the public. Because particularly if you've not been to the doctors for quite some time, you know, perhaps if you've not needed to call, or you might be unaware of some of the changes that have now happened, it's an impossible task, but it's something that will continually be needed, I think, and I don't know how best we do it, but we need to continually do that in some way as best we can. So thanks.
Thanks very much, Karen. And thank you both. Obviously, a very interesting area of work. And I think you can tell from the response from the members of the committee that we would like to have some continuing feedback as you get the final results and look at ways forward. It seems to me that it's a hugely important area because there's a lot of good things that can come out of things we've had to do because of the pandemic. And I wouldn't like to see those lost because of people's issues linked to them. You know, I don't want people to end up feeling completely against any sort of change of methods of consultation just because of some bad experiences. I don't want us to lose the good because people have had difficulties. And I do, just as a personal contribution, listening to people and my own experiences, one of the big barriers, it seemed to me, is getting through to your practice on the telephone. Not necessarily that you want to see anybody or go in or anything, but just at times when it seems to be the only way forward, it's really hard. So if we can look at ways to ask people barriers and try and look at ways of overcoming perhaps fairly small barriers to allow much better access in other ways would be good. And Robin, did you want to add to that?
Yeah, just one final bit of data for you. So we're at Ponteland, we're auditing our telephone calls in and out of the practice. And for the last 4 weeks on a Monday, the number of telephone calls, so the population of the practice size is 10,200 patients. For the last 3 or 4 Mondays, our activity has been 2,500 telephone calls on a Monday. And then the average for the rest of the week is around 1,800 to 1,900. Now, I don't know how that compares to, say, Northumbria Police, who cover the whole of Northumberland, but that's one practice. Practice size of nearly 10.5, and we're having nearly 2,500 telephone calls in and out of the practice. So managing that with numbers of staff is a massive issue, and demand is massive. Just that point.
Yeah, and I think one of the conclusions that this sort of research may lead to is whether we need to invest more in telephone services. You know, perhaps that is the way forward, and perhaps it means investment there instead of in other ways, who knows. But these are the good things we could learn, aren't they? We can see just where barriers are, where we can save on one thing and perhaps invest in another. Jane, final point from Jane, because we are just over time.
Just to say, you know, that the more and queuing here, the more you increase access, we haven't nearly reached the saturation point yet. So it's not so much access, it's the capacity. And what we're trying to do is make a small number of people responsible, as Robin has just illustrated, to answer an incredible number of questions. And not probably only 5 or 10% which actually need to be answered by the practice. So it's not access, but it's capacity to receive that access.
Absolutely. Thank you all very much. I'll move us on because we have item 4, the presentation from Pamela about PCNs, their development and what the future looks like. We are running a little bit late, so we'll try not to spend too much time on this. But on the other hand, it is a very important area, I think, because PCNs are picking up more and more work responsibility and function, and should continue to do so, looking at the legislation relating to ICSs and ICBs. So I think it's very useful and important for the committee to understand how they're managing this, how they're developing, how they're resourced, and how they feel about going forward into the future. So over to you. Thank you, Pamela.
Thank you, Janet. I'll put my slides up, but I will keep this to a minimum where possible. Can you all see my slides?
Yes, thank you.
Okay, I've lost you from my screens, but that's fine. So Pcn development, yes, you wanted me to bring back just an update as to where we're going, how Pcn's developing, and also what the future now holds with the integrated care systems that will come into play next year. And that changes us from a members organisation as a CCG to a much more wider perspective, focused on whole systems, all providers, voluntary sector, communities, etc. So going back a little bit, just defining the role of PCN. So in the PCN prospectus back in 2019, the main ambitions and aspirations of developing in PCNs were to stabilise general practice, help solve that capacity gap, which is what Jane's referring to around how we look at skill mix, how we evolve that workforce and increase it to increase that capacity. They were aspired to become proven platforms for further local NHS investment with multiple providers, dissolving the divide between primary community services, and then systematically deliver some new services within the new long-term plan and thinking about the populations that they serve specifically. So they were the national aspirations and ambitions of the PCNs initially. So within Northumberland, obviously 2019 was when they came about, they established, and then COVID hit us less than a year later. So the trajectory and the plans and the development that networks have been on has been very much driven reactively to what's happened over the last two to 3 years. And the variation in the progress about the PCNs, where they've focused on their development and their maturity, there is a variation just within Northumberland. So engagement with member practices has been affected in part. Some have gone to full mergers across the PCN, and obviously we've got a new PCN coming from April as well, which there's different models out there. So with the ICS, it brings a further challenge, and the reliance on networks within the community is increasing. We're seeing PCNs as organisations that represent general practice. However, the expectation and the reality of the journeys that they're on is very different. And as a CCG and what we become in the future as commissioners, we're really conscious of the support, the direction and the facilitation we can give to general practice as it evolves with networks and with their system partners. So with regards to resources, there's multiple elements of income for PCNs. So they all get a generic element of income, which is a pot of funding they receive from CCGs. Each practice participating in the network does receive the payment for their contributions. They have some funded sessions for clinical directors, but it's not a full-time post. The R scheme, which is the workforce and the advanced roles within networks, including mental health practitioners, pharmacists, physios, support workers as well. And then they are, this year from October, they've received a leadership and management funding pot. They receive some development funding for their maturity in multiple areas. They are paid for care home payments, and they also have an investment and impact fund, which are based on some quality indicators and their performance across the network practices as to how they perform. As a CCG, we currently support them in a number of areas. So strategy development, financial management, their workforce planning, and then new to the whole concept of health and care moving forward is population health management and understanding their communities and adapting services to meet those needs, as well as data analysis and other bits and pieces. So we are thinking about the future and what commissioners need to do to sustain that level of support and how it evolves and matures with time. So each PCN has a clinical director and a management lead within Northumberland, and then they draw from their member practices for other leadership and inputs for specialist care services and pathways. There is variation in structures and the governance, how they operate. I don't think we've got two the same within the 6-7 that we've got coming up in the networks. Some have dedicated management support, so it's not a practice manager acting as both network manager, but some they do have dual roles in their day-to-day work. There's also gaps nationally with the infrastructure of support. So digital and estates hasn't caught up quite with the primary care delivery model. And there's still some challenges around how we house and support the new workforce roles in networks with that lack of infrastructure at a national level. So they learn and share together. The PCN clinical directors meet regularly and they learn from one another. We meet as a commissioning organisation with them on a weekly basis. We're about to start, Robin and I are about to start to do some development visits to think about the future and where we can target their maturity with them and support them to deliver that. And then obviously the locality structure that we have as a CCG, that interface with the commissioner and the wider system is going to change. So we're just looking at that at the moment as to how we share and learn across providers with general practice at the heart of some of those changes. And then we also put a framework in place at the end of last year with the CCG and the LMC to help the transition of the thinking and this representation of general practice moving forward. So what could PCNs achieve in the future and beyond COVID? So I think the main thing is understanding their communities, understanding the demographics, the variation across the rurality, the urban, the employment, the children's needs. And there's a huge programme of work that the CCG is developing to support networks and communities and stakeholder groups around those networks to do that. I think integration and relationships with the wider health and community services will develop. The growth in the workforce we're already seeing significantly. The types, we've gone up to 75 whole-time equivalents within the R's schemes for the networks, which is huge growth in that area. I think it's pertinent to the population understanding what those roles are and what they bring. The representative voice of general practice, how it sits within the system decision making, both at place and in the wider regional developments. Gaining value for money. I think there's some efficiencies about them providing together, improved outcomes for patients with specialist services and sharing the knowledge across practices and clinicians with that specialist investment. And then some engagement with the population at greater scale and the stability of general practice, for which we're already seeing the models of stability of individual practices improve as a result of networks building and developing their relationships. So active planning for the future, I've touched on slightly. So the CCG PCN framework for redesign, the representation at different forums and decision making, including the System Transformation Board and how that will evolve. I think developing their independence is important as well. They've been very reliant on the CCG as commissioners to present and shout the cause for general practice, but I think we can support them to develop that level of independence. We've recently changed the way in which we'll commission services with practices for the primary care commission services to a more network level. And then just resetting that relationship of the CCG change with practices and the commissioner. Like I mentioned before, we're no longer the members organisation. So we'll have to reset and co-design that relationship so it has the best effect moving forward. And then retention of whatever support we need to do as a place-based organisation into those providers. Leave that there. It was a bit of a whistle-stop tour.
Thanks very much indeed, Pamela. That was very helpful. I think it certainly gives me a much clearer picture of how the PCNs are progressing and where they're aiming for. I'm particularly interested in the mention you made about what they can achieve beyond COVID, helping to develop their independence and representing general practice. Because of course, once the CCGs have gone, really it's going to be over to PCNs, isn't it, to pick up this role in a way. So that was very, very helpful. And I would certainly find it helpful to have a copy of those slides, if you don't mind, because that was a really good summary of where they've come from, where they're going to and how they're getting along. Robin, did you want to come in on this?
Yeah, no, just to say thank you to Pamela for lots of her strategic thinking on this, and it's been really, really good talking this through with her. Just one point just to draw out is that John Warrington, who's medical director, and myself as medical director. John Warrington is a locality director as well, and I've also had to step in as an interim locality sort of director type role in the West, and I think we're quite well placed now to start having the conversation about how the locality meetings transition into more of a provider focus. So I think hopefully we'll be able to get a bit more traction on that in the coming month or two. But I think we are well placed to now have a grown-up conversation with our PCN providers to see, well, how do they see the future mapping out in terms of engaging with practices and other things. So it was just that point. Thank you.
That's very helpful. Thanks, Robin. And I think it's really interesting. In the early days of PCNs, I think there was a feeling in Northumberland that members wanted to keep the locality directors separate from our corporate directors in the CCG for various good reasons. And it's interesting now to see them starting to come together, which is a good step towards developing further into the future when CCGs go, isn't it? So I think it's going in the right direction. Jane and then Annie, thanks.
Yeah, I think, thank you, Pamela, for a very measured presentation. And I think it's a very, what should I say, it's a difficult situation, which I think we're well placed in Northumberland, because we do have, as with Robin and Pamela and I and others discussed on frequent occasions, we have a reasonably good infrastructure, so that when the sort of the changes happen, we are fairly confident that things won't fall apart as they may do in some areas. But we have to remember that PCNs do not exist. They are contractual mechanisms. They are a contract. They are not a being. And we don't have any in Northumberland that are in existence. So the rhetoric from the centre that PCNs will take over is a bit, I mean, it's probably has a greater chance of happening in Northumberland because we've got NPC, we've got Valens, we've got some very strong PCNs. However, I say we have to remember that there's this great chasm between what we're talking about and the reality. And what I was pointing out earlier is there is a great big black hole where finance is, and you know, they can provide all they like, but whoever's holding the purse strings is going to be, you know, basically calling the shots. So I think whilst we're in an incredibly good position in Northumberland, we have to hang on to that. We've got to remember that there's an awful long way to go, and we're making great big demands of people, and we hope that all, I just for one from the LMC point of view, pray that the expertise and good people we have within the CCG and its structures and above will be able to still be there to assist the new order.
Yes, thanks, Jane. Spot on. This is exactly the issue, isn't it? And everything you said there, absolutely agree with. PCNs are not a body on their own, and this is where we need to look at how they're developing and how they're coping and how they're resourced. It's a really interesting and important point, and I think we need to look very carefully as the future goes on. Annie, thank you.
Yes, Pamela, I'm just wondering going forward, whether, because one of the things probably you didn't mention, but then it's different from PCN, I appreciate, is about a federation model. There's some other places have sort of something like that, bring the providers together. Do you see, is this something that will be suited or to be considered by our practices in Northumberland? I know probably appreciate that probably been discussed in the past, but in terms of where we are now, the relationship is much stronger and so on. What do you think about that model at all?
I think we do have federations within Northumberland, so that the West Northumberland do have a provider alliance that they work into, and they've come together as a provider organisation, which is a separate entity to the practices and the PCNs. Valens have gone down a model of a single PCN merger. The North have a very strong alliance and a federated approach. I think with the rurality, the variation in the demographic and the geography in Northumberland, one size and one federation, which our city CCGs benefit from, doesn't necessarily translate into Northumberland as easily. I think we also recognise the autonomy of our practices as individual businesses and how they operate, but I think the PCNs is a step towards them collaborating and providing services together. I'm not convinced personally that necessarily a single county federation would give us any added benefits to what we currently have in the structure of general practice.
Thanks, Pamela. David, final comment, because we are way over time here.
Yes, thank you. Very, very quickly. Reassuring that engagement with the population is mentioned. But Pamela, do you envisage there being for each PCN a patient participation group? I know that's sort of a detailed question, perhaps too early, but might that be one of the avenues to pursue?
I think that's already started, David. We've already got some tools and workshops and support going into each network. So they have already started to develop that approach across their networks. And obviously with population health in mind, that's going to even become more pivotal moving forward. So yes, that is in place already. It needs to grow and it does need to evolve, but it's definitely at the top of the agenda for engagement with networks.
Okay, thank you.
Thanks very much. Well, thank you very much for that, Pamela, and very useful. Just one other point that members might be interested in. I don't know if you're aware that internal audit is also doing an audit of PCNs, and the purpose of that is also to add to this knowledge of how everybody's getting on, what they're doing, and also because they're auditing a number of different areas of PCNs, perhaps to learn from other people as well, swap good practice. So we're hoping that that will come up with some good work as well, just to let PCNs know what other people are doing, how they might be able to move forward too. So it's all aimed at trying to help PCNs to develop and cope with the future. So thank you all very much indeed. Quickly on to item 5, any other business. I haven't been notified of any. And item 6, date and time of next meeting, 13th of April at 10 o'clock via MS Teams. So thank you all very much for attending. That's the close of the public section of the meeting. So the recording can now be stopped. Thank you. We are now then going